thank Livia, Cyril and John for putting this together yet again. It's a pleasure to be able to speak to a lot of old friends, and also to follow on from Frank, who I've had a tremendous admiration for all his work, even the very early days that no one could remember when he did studies on vegetarian diets and blood lipids, which I still show frequently, but because they were quite seminal. So that's me. These are my lifetime conflicts of interest, which I put down as to, if you're not on the list, please come and see me later. Donate to my research. Frank's visit to Toronto just a little while back was welcome and opened up an important discussion. Who benefits from a low GI diet? I think that's something that even those of us who've been focusing most of our attention in diabetes have to ask, because the progression from diabetes, from normal to pre-diabetes to diabetes, and then on into more severe diabetes, are a spectrum, and we tend to lump things together with perhaps artificial classifications. Frank went through very nicely his study, a nice metabolically controlled study. To me, the interesting thing has always been that Frank, I never asked what the waist measurements were of these people, but presumably they were 100 and something plus centimeters, presumably. But let's assume that these were hopefully something like the metabolic syndrome classification for weight. BMI, certainly the unhealthy. Blood pressure is 132. But basically diastolic glucose, triglyceride, HDL, quite nice. 20% was the total metabolic syndrome. And I think the black-white ratio is the reason why you have this lower effect in terms of metabolic syndrome, which made me think, was there anything specifically different? Have we ever done studies of glycemic index in people of black African origin and living in Western nations? And I don't know that we have specifically. So I don't know from the diabetes point of view where that takes us. So we thought we'd just take a look at some of our recent studies. We looked at our most recent study, which was a low glycemic index canola study. Canola was the oil that we used to make a canola bread, which was quite tasty and high in fat and low the carbohydrate content of the bread. Basically, most of our diets compare low glycemic index with high wheat fiber diets as a control. So some would say it's a positive control. But just looking at the sort of people that we have, our ages are a little bit older than Frank's, 59. Body weights, BMIs 30, 31, very similar to the non-diabetic people. Waists 106, 104, 105, so these are definitely large people. Glucose levels, this should actually be hemoglobin A1Cs. No, this is glucose 7.5 to 7.7, so that is the big difference there. Hemoglobin A1Cs greater than 7.1, basically split equally above 7.1 and below 7.1. So these people are on the borderline for those who we would want to get below 7. Our LDL cholesterols, unfortunately, are fairly low. Most of these people are statin. The vast majority, statin takers, who they're diabetics, so they have low LDLs. Their HDLs are also not particularly high, but they're not low. And their triglycerides are getting up a little bit. These are in millimolar scale. Their blood pressures, on the other hand, don't leave a lot of room for further improvement. So that's the group that we're looking at. What do we find? Well, we do have a few people with blood pressures in the range of Frank's people. 130, over 130. The majority are under 130. But if we look at the change in hemoglobin A1c in those who have low blood pressures versus those who are high blood pressure, you see virtually no difference in the treatment difference between wheat bran and low glycemic index, low glycemic load, whereas you do see the difference in those with the high blood pressure. A long time ago, very early on, Jerry Reven made quite a lot of emphasis on the blood pressure, metabolic syndrome, hyperinsulinemia association. And so this is what we think is probably due to those who had a greater degree of insulin resistance, probably greater glycemic excursions, are those who show the greatest effect. If you took this group, you'd get no effect. And the results went on to look at the waist-to-height ratio as another marker of insulin resistance in this group. And if you took this group, this half of the population, you would have got no effect. If you took those who had lower Framingham risk scores, lower baseline CVD risk, again, you'd have got no effect in terms of glycemic index. Whereas if you took those above at the higher level, that's where we saw the effect. These are diabetic folk, obviously, these are people with diabetes. So in the diabetic, we would suggest that those at the upper risk range with the higher blood pressures are those who may benefit from a glycemic index change, whereas we don't find it in those who are lower. We thought that was interesting. That was just one study. So we looked at the last studies we've done over the last 8 years. This is total, I think, about 650 people on these slides. And what one sees, this is the low glycemic index diet, which went on for 6 months. We're just showing the first 3 months because we have 3-month study data for most of our studies. These are the sort of changes. This is a low glycemic index study, straightforward study. This is a study with nuts, reducing the glycemic load as opposed to muffins. Same sort of load effect. This is a pulse study, a low glycemic index study, favoring pulses as being the beans, peas, and lentils as being the major driver of glycemic index. And this is the Canola study. So they're sort of comparable sorts of studies. We thought we'd pool these because they're the same group of type 2 diabetic patients, recruited with hemoglobin, baseline hemoglobin A1c is 6.5 and above, all treated with diabetes meds. And what we saw when we combined them was a picture like this. This is the 650 people. And that was interesting. We looked at the hemoglobin change from baseline. So this is we divided them into, these are the quartiles. And we looked at the quartiles less than 6.75, 6.75 to 7.1, 7.1 to 7.55, and above 7.55. And what one saw was significant treatment differences, becoming more significant as one got into the mid-7s, and then falling off with no treatment difference. That's not because you don't fail to reduce the hemoglobin A1c over the length of the study. But what it means is that the wheat bran side, the wheat fibre side of the diet seems to be catching up at this point. In fact, overtaking at this point. And at this point, your differences are very small as your hemoglobin A1c is lower. So up to about 7.1 to 7.55, up to 7.5, you see a progressive reduction and then you level off. And at that point, the wheat bran joins up. So I think there's something interesting going on here. We've still, I mean, these data, I've only had about 48 hours to think about these data, so to be honest, I'd be grateful for any thoughts you've got. But you asked me to say what was new, so I'm trying to tell you what's new. Doesn't mean to say it's been thought out. If one looked at, again, the higher systolic blood pressure and the higher waist, these are the higher waist, the lower blood pressure and the lower waist, you see very little effect, as we've shown before. I'm sorry we haven't got standard error bars. And at the higher systolic blood pressure and the higher waist, you see the effects. If you took this group, the top half, you'd say we have no effect in diabetes. If you take the lower half, you'd say we had very good effects in diabetes. So I think that there are differences here that we've still got to focus on, and I would like to see that projected backwards. It's interesting, if we go back, David Ludwig's name was mentioned, Frank mentioned earlier on as their consultant. David's studies looking at glycemic load versus low fat and weight reduction showed that you only saw the difference in the low glycemic load diets improving weight loss in those whose 30-minute insulin levels were greater than 57.5 microunits per mil. This study, those are the greater people. The lesser people show nothing. There's no treatment difference. So these treatment differences, I think, are important in terms of insulin resistance. Simon, here I think I'm correct in quoting him. He can correct me if I'm wrong. Looking at baseline BMI in the Nurses' Health Study, the glycemic load only really makes a difference if you're over 23 kilograms per meter square BMI. For those of you in the room who are all below 23, we don't expect any difference at all. Is that right, Simon? Anyway, so they've all got good genes, yes. And it's interesting, if we took Fourier's study looking at fatty liver, the insulin-sensitive people is cross-sectional. Insulin-sensitive people, it doesn't need to matter whether they're on a high or low glycemic index diet, but it does matter if you're insulin resistant. If you're on a high glycemic index diet, you have more liver fat. So again, differences that one sees in the insulin resistant as opposed to insulin sensitive. Again, going back to Simon, BMI, if it's high, you get a cross-sectional increase in CRP along with glycemic load. If your BMI is low, the slope and the significance is less. And talking of CRP, Tom did a study with mean baseline hemoglobin A1Cs of 6.2, so that's below our range. And at that range, although he saw no hemoglobin A1C difference, which to us is not so surprising, he did see a nice CRP reduction over the length of the 1 year that he fed the low glycemic index diet, not seen on a low-carb, high-fat diet or on the high-GI, high-fiber diet. So, again, I think one wonders whether there are going to be times when the glycemic index is more useful and where, depending on where one is, so one uses different markers to assess one's effectiveness. I want to say that perhaps we should be using ACCOBOs more to look at some of the basic mechanisms of glycemic index, because at least the ACCOBOs study over long term looks as if it reduces cardiovascular events, ACCOBOs versus placebo. Admittedly, it's a small study in terms of numbers, but nevertheless it seemed to turn out quite nicely. And ACCOBOs is a way of converting the diet into a low glycemic index diet without the introduction of any other features. so perhaps could be used to explore the effect over the healthy volunteer right the way through to the more severe diabetes situation, without other confounders. I just want to pay tribute also to Geordie and his group with Predimed, obviously nicely shown here with nuts, extra virgin olive oil, which will, as it were, reduce the glycemic load of the diet on what was already, I understand, selected a low glycemic index type Mediterranean diet. So showing some nice results in the long term. So in conclusion, insulin resistance and associated risk factors may be important determinants of a low GI diet on glycemic response, even in type 2 diabetes. And as glycemia improves, in other words, as one pushes oneself more towards normality, are other risk factors more influenced by GI, such as CRP? I'd like to thank all my colleagues who put this together. Thank you.